We have a lot to look at here. It looks like the value of family peer support just won by a nose. Thank you so very, very much for contributing to that. You will be getting information from us about Mental Health Awareness Week, and we will be sharing exactly how we're going to be moving forward. Thanks so much for your feedback. All right, now I will do what I was supposed to do. I'm going to introduce Melinda Baldwin. Dr. Baldwin is the Chief of Child, Adolescent, and Family Branch in the Center of Mental Health Services at SAMHSA. Now, to make certain everyone understands this, Dr. Baldwin has taken the place of Gary Blau.
Dr. Charlie.
So I want to make sure you know that up front.
I'm fine. How are you, honey?
So Dr. Baldwin is a subject matter expert.
I know it.
We've got someone who is not on mute. Dr. Baldwin is a subject matter expert in behavioral health, trauma, program evaluation that's grounded in implementation science, and its intersection with child welfare and mental health practice and policy. She comes into the position from being the special assistant to the director of the Center for Mental Health Services. Before coming to SAMHSA, she worked at the Children's Bureau, leading their work.
Your phone.
Let me go. I'll start that sentence again. We had a little bit of an interruption. Before coming to SAMHSA, she worked at the Children's Bureau, leading their work in behavioral health and trauma. While there, she partnered with ASPE, the CDC, and CMS to conduct research on children and youth in congregate care, the intersection of behavioral health care, fetal alcohol syndrome disorder, and the impact of substance use on child behavioral health care. She led the expert group in the development of a framework to design, test, spread, and sustain effective practice in child welfare and a roadmap for collaboration and effective evaluation of tribal communities. Dr. Baldwin's interest in this work began and is shaped by having grown up in São Paulo, Brazil. She has had extensive field experience, beginning on the front lines as a social worker with families in the child welfare system, training resource families, conducting forensic sexual abuse interviews, and providing behavioral health services to victims of sexual abuse and their families. She was the director of child welfare at SAMHSA Children's Association, managing the continuum of services to children and their families from community prevention work to therapeutic residential services. Dr. Baldwin was a faculty member at Northeastern Illinois University, first as the field director and then as a faculty member teaching across the curriculum. She has a PhD in social work from the University of Illinois at Chicago, an MSW from the University of Illinois at Urbana-Champaign, and is licensed as the clinical social worker in both Illinois and the District of Columbia. And I'm going to invite all of you to just sit back and relax and let's learn from Melinda. She's bringing such incredibly rich experience to this position. And please, one more reminder, make sure we have your questions in the chat box. Thank you, Melinda.
Oh, well, thank you, Linda. And I am so honored to be here this afternoon. And I've had the pleasure of getting to know Linda since I started the position. So when she asked me to come, you know, I was just overjoyed. So thank you. And I look forward to a dialogue at the end of some information I'm bringing to share with you today. So what I thought we would do today is to talk a little bit about family and family engagement. One of the first questions it seems like routinely asked since I assumed the position is, what is your position, or what do you think about family involvement, family engagement? So I thought, we should talk about that, and a little bit about kind of my experience and how I came to believe what I do. And then, as you will learn about me as we get to know each other, is that I'm a real data nerd. And so what I thought I would do is, we just got a lot of data from our uniform reporting system, and then I ran some data on our programs. And so I just wanted to share that with you. So hopefully I can inspire you to be as much of a data nerd as I am. And then I want to talk to you a little bit about some of the things that I'm thinking about. And as you'll find, and as my husband always says, Melinda, you ask too many questions. And so that's how I interact with the world. And you guys will learn a little bit about that as we get to know each other. So next slide, please. Can we move to the next slide, please? There we go. So since we're talking about family, I thought I would introduce you to my family. It's my husband, my mom, and if you can believe it, those are my twin girls. Kate and Emily are fraternal twins. I also have a stepdaughter that lives in Minnesota who's currently expecting, so that's exciting. And she wasn't with us for Emily's graduation in this picture, but I wanted to introduce you to all of us. So next slide, please. So when I think about parent and family engagement, I was, in answering this question and doing this thinking, engagement is just not quite the word that I would think about in working with families. Partnership comes to mind, but even that doesn't quite capture how I understand and how I've worked with families in the past. Because language is so very important. And I think, if anything, this summer has taught us how each of us perceives and thinks about language, and how we internalize that and perhaps label ourselves in different ways. But I wanted to tell you just a brief synopsis about how I came to value working with families and what shaped my experience since. So I graduated from the University of Illinois with my MSW very young. And I came to this work being a child advocate. Often when I was growing up, I didn't feel like my voice was heard. And so I wanted to make sure that children's voices were heard. And that's, everything I did in my MSW program was towards that end. And I came to be a child protective services worker with that same goal. And, it wasn't going that well for me. I need to be really honest. I was really engaging with kids, but my cases weren't, kids weren't returning home, and they weren't going as I had wanted them. I was still trying to kind of understand what that was about. And being a young worker, those of you in the audience can remember that, we used to have our case files in binders. And, being a new worker, I was always getting the cases that had multiple 3, 4, 6, 7, 8 binders. And that was one that I had been assigned. And there were 4 children in this family. All had been in foster care for a long time. And the mom was working really hard. She had a substance use disorder and had some issues with domestic violence. And the little girl in the family had been sexually abused. So there was lots and lots of issues. And I was a little overwhelmed, to tell you the truth. And so I took out some of the case files to her home and thought, well, how are we going to do this? Because it was really important to me that I better understand how to work with families so children could go home. And it became really clear to me as, we sat in her living room. I was on the floor, and how you remember certain things about where you were when things happened. And I had this all laid out on her coffee table, and she was sitting next to me on her sofa. And it became really clear to me that the only way we were going to do the right thing for these kids was that if she and I became partners, and we had to join in a way that that moved everything forward. And, you know, I was 22 years old. I didn't even much like to babysit when I was a kid. I didn't know much about being a mom at that point, but I knew how to write a really good court report. I was really good at getting services, and I could advocate like nobody's business. And so what she and I decided that late afternoon was that we would become partners, that she would help me with the court reporting and whatnot. I was going to help her whenever I could, but she would be the mom, I would be the caseworker, and we would be joined at the hip basically, so we could get her children returned to her. And that was like an epiphany for me, that this was a very different way than I had approached working with families, that it had to be this working kind of partnership, it had to be a mutual understanding. And so that taught me so much and had just really influenced the way I've approached the work that I do. And so I no longer think of myself as a child advocate, but as a family advocate, because, you know, in order for kids to thrive, they need to be in families that have the support and the resources they need for them to thrive and for them to raise their kids. So that's how I come to this work and how I see working with families. Next slide, please. So let's talk a little bit about data. And I want to talk to you about 3 different kinds of data, but particularly about national data. And then I want to share with you some of our SAMHSA data, our branch data. And then we'll talk just a little bit about the data that we get from our state family network grants. Next slide, please. So the next kind of group of slides is going to be data that we collect through our mental health block grant. And as many of you are very much aware that another branch, another division at SAMHSA administers that to all of the states. And through that money that they receive, they need to report the numbers of folks getting services and lots of other kinds of data about the people receiving services. So those are both adults and children. And so you'll see from this map, the states that report what we call client level data. So the client level data is what helps us understand more about the people that we're serving. And so we're going to talk a little bit today about just an overview of the children receiving services and some of their characteristics, such as school attendance and where they live. Next slide. So just a little bit more, because it's always really important, I think, for folks to understand where this data comes from. So the basic client information, which is what we're going to talk about today, as you'll see in the one bubble, comes from 42 states, the District of Columbia, and 3 territories. And so there's 1,835,279 unique people that is represented in this data. And then the SHR means the state hospital readmissions data. And so we get that from 31 states, 2 territories, through about 8,000 discharge records. And in that is about 7,000 unique people being served. And so as you see, there's about 1.8 million people, or children, excuse me, served by the state mental health authority. Next slide, please. So the other thing to remember for those of you, you can find your state in this graph, but the majority of children in this data set are served by just 10 states. And this is all this data we're going to talk about is from 2019. So you'll see California, Ohio, Pennsylvania, Texas, and then the rest of them there are the majority of the children that we'll talk about today. Next slide. And of course, this slide and the next one are talking about what's missing from the data. So it's really important, as you guys all know, that when you look at data such as this, it's important to know what's there, but what also isn't there. So I don't want to spend too much time on this slide, and the next one, but just so you know, there is race and ethnicity data that is missing from some slides. And so you can get a sense from here where that may be. And then if you go to the next slide, you can also see that the residential status, some of the school grade and attendance and arrest statuses of adults are also not in this data set. So this just gives you a sense of where there's missing links in some of this. But the good news is we have a, even with some of this data that's missing, there's a robust data set that we can look at and we can learn something from. So next slide, please. So this one is just to show you that, and the blue line is the US Census population, but children who are 12 years old and older make up half the children that we serve or that are served by your community mental health centers. So I'm sure this doesn't surprise any of you here, but this just gives you an illustration of what that looks like. Next slide. Now, this is a really important slide to me, especially because, as Linda said, I'm very interested in how many children are in congregate care situations. And as you can see, almost 97% of children are seen in community mental health centers. And very few are served in other kinds of inpatient or residential treatment centers. So this is, this is amazing data to see. Next slide, please. The other thing I wanted to share with you is some of the diagnoses. So neurodevelopmental and trauma and stressor related diagnosis are the most common diagnostic categories that we see in children. And as you all know, and as I experience, is often children have several diagnoses, or they may change over the course of time. So this data is a snapshot in time. And so this is where kids were being diagnosed in 2019. Next slide. And I am sorry to bring, I'm just trying to get some of these notices that keep popping up on my screen so I can see the slides. I want to talk to you a little bit about school attendance next slide. Because as you are aware also that it's really important, for the kids that are in our families that go to school, because there's a lot of positive structure and association with the children attending school. So as you can see, is most children, almost 90% of children who are receiving services through state mental health authority programs attend school. So that's wonderful that that's happening. And if you go to the next slide, that helps break it down a little bit more. So if you look at this by age, now there's a little bit difference in terms of the red indicates Census Bureau data from 2018, and the blue is 2019 data that we have at SAMHSA client level data. So as you can see, children with socio-emotional disorders and other kinds of mental health challenges don't attend school as much percentage as children in the overall population. They're pretty close. And it stays pretty consistent, from about age 5, 6 through 17 and 18. As it falls off in the regular population, it falls off a bit, but not quite as much in the children that are receiving services. Next slide, please. So children with a socio-emotional disorder diagnosis are more likely to attend school than those that haven't been labeled as such. So it's between 83% and 91.3%. I haven't run any statistical analysis to see how significant that is, but it does, I think, worth mentioning and worth thinking about in terms of, does receiving a diagnosis help kind of bring in some of those other services that may not be available without it, that may then help with engaging in school. Next slide, please. It also doesn't seem to matter what a child's diagnosis is. And so as you see, these are the same diagnostic categories that we saw on the earlier slide, but the percentages of kids, when you look at them this way, are pretty much, I mean, they're very similar, anywhere from, 89.4 to 92%. So very similar. Next slide. And then this is also, I think, really important, because what it looks at is, what is the percentage of children that are at grade level? And so as you see, the blue part of the slide are those children that are being served by a state mental health authority that are below their grade level. The red represents those kids that are at grade level, and then the green is those that are above their grade level. So there is a high percentage of kids that are below their grade level. Next slide. Whoops, hang on, I'm moving my notes here. And this is, so we're going to switch gears a little bit and look at where kids are living who are receiving services. So for the most part, this is looking at admission, and then at the start of the reporting year, and then at the end. Most 92% of children are living in a private residence, meaning in a home. A very small percentage, 3.6% of children are living in foster care. And then, as you can see from the other categories, the very small percentages of children living at other places, in institutions or residential care or other kinds of residential facilities. So I'm wondering, Linda, since we have more time than I had anticipated, should we stop for just a minute to see if people have questions, or should we finish and go all the way through?
We can definitely stop for a minute and see if people have questions. If you have questions, you can either put them in the chat box right now, just if you have questions on what Melinda's talked about so far, or Kelsey has asked that we put them in the chat box, because we've tried opening up mics before and I guess that doesn't work so well. So if you would put those in the chat box, and we will we'll get some answers from Melinda, or her thoughts. It may not always be answers. None of us have all the answers, do we? But we can get her thoughts on some of this.
And I know there was a lot of information, and I've been looking at it for several weeks, and you guys are just looking at it for the first time, so I understand that.
Now we do have a question, Melinda, that I think is interesting, and I hope I present this correctly. The question's from Barbara Callahan, and she asks, is the fact that most youth are served in the community because we have less residential programs? Should we be looking at secure detention or other juvenile justice programs to see if that's where youth are winding up? Are your statistics just mental health statistics, or does this cover juvenile justice and education placement?
So that is such an important question. And so these are statistics only from our uniform reporting system, which is where the state mental health authority, who gets our block grant money, sees their kids, right? So that's the only place this data is coming from. However, you bring up such an excellent point about how some children end up in a juvenile justice setting because their behavior is such that it lands them there, right? And so that's, I mean, we worry a lot about that for adults, and we also worry about it with our youngsters who, especially as they become adolescents, you know, may be, as we refer to them, cross-system youth, right, that are in both systems. And so I think that's a really good question. I don't have the answer to that, but I think that, you know, we should, in our states, we should think about it. And, you know, I will look into it to see if there's a way we can find that out for kids. I know that the adult statistics, this data has that for adults. I don't think we have it for children, but I will find out and let Linda know.
Great. Now we have a question from Lisa Lambert. Does this capture kids with SED who receive services via Medicaid, not state mental health authority?
Well, it captures those that are seen in community mental health centers, right? So some of those folks are using Medicaid, others may not be using Medicaid. So, but this doesn't capture children who may have private insurance who are being seen perhaps by a local therapist or something. It does not capture those children.
Right, okay. Jerry Melinda has a question. Jerry, it's so great to see you on here. Will the statewide network grants continue, and will there be an increase in these grants?
Well, that's a good question. Let's table that question until after we talk about the SAMHSA programs, if that's okay.
All right, Heather.
Maybe that's our segue, right? We'll talk about that. So the next slide, I just wanted to give you all the breadth of the programs that we have in the child and adolescent and family branch. So this is a list of all of them. For those of you that are familiar with the programs, the new ones that you see here are the disaster grants. I call them the disaster grants. And these are new programs in the branch that are very time limited and are really speaking to disasters that happened in 2018, such as Hurricane Michael, some of the fires out in California, other kinds of disasters that happened then. So we first got the school-based programs in the branch, and then the adult and state programs were given to other government project officers, but we formed a mini team, which I'm heading up, that's out of the CAFB branch as well. So these are really looking at providing mental health, behavioral health services within the schools for children and their families who were suffered trauma and other kinds of related issues from those disasters. But I know what's in all of your minds in terms of how, you know, how does COVID and all of that fit in? So these grants applied for, they submitted their applications in February, and they were awarded their grants in April. And we went, you know, we all went home and started teleworking in March. So they've really had a lot of challenges in terms of, this is what we said we were going to do, and this is what it looks like now in our community. And so they all look different across the country because schools are all functioning differently, community mental health centers are all functioning differently. And so it's been quite an implementation challenge and exciting at the same time to see the innovation and the creativity that folks are bringing to the table to make sure that services are being delivered in the ways that are helpful to folks in their communities. Excuse me. The other thing to know, so we talked a little bit about how the data is collected in the uniform reporting system in the state mental health authority just recently. Some of you know how we collect data at SAMHSA. It's through the SPAR system. And we collect two different kinds of data. We collect individual client level data like we just talked about, and we also collect infrastructure data. So what I've chosen to talk to you today about is that client level data, because it mirrors very carefully and closely the data we've already talked about. But, you know, when we talk again, it would be great to talk about some of those infrastructure pieces as well. And a lot of those is what the state family networks work on. Next slide, please. And just so you know that there are 2 technical assistance centers that help folks work with children in the communities. One is NTAC, and one is, of course, as you know, the National Family Support Technical Assistance Center. Next slide. So here, if I was still a professor, which I really miss, I need to tell you guys, if you can't tell, is remember what we talked about before, and then thinking about what we're serving in CAFB. So this is the age breakdown of all of our grants in terms of the percentages in the different age categories. So as you can see, overwhelmingly 38% of our grants are seeing young adults over the age of 16. And then the next percentage is adolescents between 13 and 15. So the category of adolescents from 13 to 25 is over 50% of who we see. And then between 5 and 12 is about equal there, and then under 5 is a small percentage. And so total, this represents 6,841 children being seen. So that's our total N, so to speak, the total population. And that's the total population for all of the slides. So the next slide is to give you a sense of, by gender, the kinds of children that we're seeing. So it's majority male, about 53%, or 3,634, and then female is slightly less than that at 45%, or 3,055 children. So go back to that one. I want you guys to remember those percentages, because we're going to break them down a little bit more. Next slide. And so here's when we look at a racial breakdown. These are just the folks that are being seen in our discretionary grants. And so you can see that 56% of them self-identify as white. About 24% of them self-identify as Black or African American. Another 9% as multiracial. And then none of the above is actually that 5.6 band of color. And then the others are much more minimal than that. And you can kind of get a sense of that with that pie chart. Next slide, please. And then when we look at ethnicity, 77% of them identify as non-Hispanic, and 23% of them identify as Hispanic. Next slide, please. So as we were kind of breaking this all down, I thought, well, what if we did looked at gender and age, and how is that going to break down? So if you look at the children less than 5, and we know that's a really small percentage of children, so you can already see that the numbers, of male children being seen that are less than 5 years old is only 195, but it's overwhelmingly most of the kids. Females, on the other hand, 38.2%, 121 children identified as female are being seen. So that's a little bit different we're getting a little bit different picture than if we kind of collapsed the ages together. So then the next slide, and these are, let me just back up and say that these age categories are the way our system gives us the data. So this is the way we can look at it. So here it's starting to look a little differently, right? There's a few more males being seen than females. And this is from ages 5 to 9. So again, as I'm thinking about this, thinking about the reasons why this might be, we know that, sometimes boys have more difficulty adjusting to school and may be a little bit socially, developmentally behind, but that probably doesn't explain this. So anyway, your thoughts would be interested, I would be interested to hear in looking at this data as well. Next slide, please. And here we look at children from the ages of 10 to 12, and we see that the percentages are shifting again. The numbers of females are growing, the numbers of males slightly coming down. So it's starting to approximate what we see overall. Then the next slide are the young adolescents from 13 to 15, and it's almost getting really close to more even, 48% versus 51%. And then in the next slide, the young adults, it's almost it is the same, just a couple adolescents different, so 48 and 48%. So as we think about this, it's interesting to think about who is accessing our services in terms of gender and how that might impact how we think about our services and what it may mean. So what we don't have here is the infrastructure building and capacity building pieces of the SAMHSA data. So that's what I'll share next time as we get more facility with it. I do just want to put in a plug for those of you that do work with any kind of discretionary grant, whether it's with SAMHSA or another agency, is how important collecting this data is. Because often it's one of the few mechanisms we have to look across the country to see who's being served. So please, it's my one plea to take those data entry and data collection requirements really seriously, because then we can really take a look at what's happening. So I thought we would shift gears a little bit now and talk about some of the things that I've been thinking about and really want to engage you as a thought partner in some of these areas. And some of them we've talked a little bit about. The first is the importance of data. And I can't stress enough your role in collecting that data, our role in making it available to you, and also that we engage with one another in understanding it. Some of you may come back and say, Melinda, I think you're all wet in breaking down ages of children by gender. I don't think that means anything. And that could be. But that's why we need to engage in this dialogue and talk about what we see in the data. The other is the importance of language. And this is critical that we maintain a discussion and an open forum for talking about the words that we use and how we think about them. We also evolve with our language. And so I think that if I remember back with some of the terms that were used in my early psychology texts, they were abhorrent when we think about them now. But hopefully, as we evolve, as we become, we approach this with humility and listening and whatnot, we become much more aware of the power of language and how we can be much more sensitive and appropriate and just really use words that help people become more resilient, help people heal, and strengthen our families. The third thing that is really near and dear to my heart is adaptation. And as we think about the role of evidence-based practice that we talk about a lot in our field, because it's so important that we implement things that work, right? And that we know work. But in order to do that, we may have to adapt certain kinds of interventions. We may have to think about how it might work in this community in Kansas, may not work in this suburb of Chicago because of the different contexts, the different challenges that people are facing. And so what does that mean in terms of what kinds of interventions our children are receiving? And how can we ensure that those critical components of those interventions, the ones that we know help people grow and heal, are being implemented? And often that means some adaptation. And so what does that look like? And so those are important conversations as we move forward. One of the things I've been spending a lot of time on is thinking about trauma and the role of trauma-informed care in our, community mental health centers and our primary care settings, and just settings where our children, interact with helping people. And so often what we're hearing from stakeholders is, how do we adapt the interventions that we know work but don't quite fit in our communities? Then the last thing I want to talk about in terms of what I've been thinking about is how we think about family support roles and engagement. Now I'm using that word again, partnerships. But when we're talking about our young or our older adolescent young adults who are often still living with us. My one daughter didn't come back. Kate didn't come back from college. She went on and got her own apartment, but Emily moved back in to go to graduate school. So as many of you know who are parents of young adults, is that parenting role continues, but it looks very differently. At least I found for my children as they become young adults. And so how does the support that our mental health centers, that our other support systems give to families, what does that look like? And how does that need to shift so that our young adults can be successful and they can make that successful transition into adulthood? Next slide, please. And so when I talk about asking too many questions, and sometimes my husband is just like, sit down, I can't, no more questions today. But these are some of the questions I often think about when folks ask me, different difficult problems, right? I ask often, well, how else can we look at this? Is there a way is there a perspective, a way of looking at a situation that we haven't considered? What have we forgotten? Who's not at the table? Whose voice do we not hear in our discussions? And how can we bring them to the table? What would be most helpful to the folks that we're trying to serve? Often that's a question we don't ask, right? Because we think we know best. So I think that's really important, is what would be most helpful to the folks that are most impacted by the situation, and who will be most affected by the decisions that we make, and how will that play out? So those are some of the questions that I think about as, you may ask me questions, or as we pose questions to one another, that are tough questions, things that don't have easy answers. But I'd like to just finish the last two slides of my presentation by saying, this is my way of saying I have an open door policy. And so there's my contact information, my email. Given that we're all working virtually, the easiest way to reach me is by email. And certainly, as Linda knows, sometimes I do get a little busy. So I am not offended at all if you reach out to me again and say, Melinda, I asked you a question. Can you please help me with this question? So please do that. And there's my contact, and Linda will have it to share with you as well. Next slide, please. And then I just want to thank you and for all the work that you do, because I know it's not a 9-to-5 job, and you're there for families when they really need it, and really understand what they need and when they do need it. And also to talk a little bit here at the end about, and whoops, excuse me, that is my phone, is to think about hope in this time of being in the middle of a pandemic, having different school schedules, having parents work at home, maybe now unemployed, and what does hope look like? And I think, this image captured it for me in terms of hope is still within us, right? And is still in that interaction between us. And although that the relationships, the way we communicate is different, it's still there. And to me, it's those spaces in between where we connect with others. And so in this time where we can't see each other face to face, we can't offer that hug. Often we need to find a way to still make those very human connections. So I just want to thank you for all the work that you do, and it is so appreciated. And thank you for inviting me to talk with you this afternoon.
Melinda, thank you so much. I'm going to ask that we keep Melinda in the spotlight because we have so many questions. So let's see if we can get some of these answered. So the first question, Melinda, is why isn't help available in the in-between? We know this area very well, where we would have more preventative services before our kids wind up in group homes or detention centers.
I think that is, that is a critical question, and one in which we need to do more thinking about, because we don't want to ever be in that position, right, of having to make that choice or to take our child to a residential facility because we can't, their behavior has gotten to the point where we can't manage it. And so I think we've got to have those conversations and talk about what does that look like? How can we, what seems to work? What can we augment? And I'd love to hear from you all about what you think and what you're seeing works. We know what doesn't work often, right? But we really need to start concretizing and understanding better what does work. So that's a wonderful question and one that is on my mind so often.
Great. So we have a question from Donna Fagan. What do you think about the number of children who are significantly underserved by special education services? How do we help those kids receive better services?
That can often be what makes a child successful in school and what doesn't, right? Is that extra support that children will receive. One thing I didn't share with Linda is that I spent 4 years working as a school social worker. And so in the thick of trying to help children get those needed services in schools. And so I think it's a lot of advocacy, helping get 504 plans, helping get IEPs set up, but that IEPs that are meaningful, that will really help in terms of what the child needs. And that's what's critical. And so I think it takes a lot of advocacy with your local school system and, just not giving up. And also engaging your school system at times, not only with specific children, but also as an ongoing dialogue, so that if there are services that could be acquired that, you've identified as would be helpful, those things can be gotten together before, the situation for a particular child is dire.
Okay. We have a question back to the data. Melinda Brumet says, looking at the charts, I am wondering about culturally linguistic families. that have stigma around mental health and do not go to get the help they need. How are we going to reach them, Melinda?
You know, I think that's a tough, it's a really tough question, because we know that mental health and the stigma of receiving help for mental health challenges is thought of very differently in different cultures. And often because of linguistic barriers, it's even harder to bridge those gaps. And so, you know, the easy answer, right, is hiring folks that are from those communities, that can not only help the organization better understand the communities, but also make services more accessible. And so I'm a true believer that it's cultural humility that brings us to this work, not that we need to, you know, change the way families think about it, but how can we change our organizations to better meet families where they are, and better help them, you know, so their kids can thrive in their homes and in their school systems.
All right, Barbara Callahan has another question about the data. Can we project from this data anything about substance use disorder?
You know, I wouldn't, just because I think it's limited, but you know, that's certainly data that's important to look at. And what we do know, right, and I know, and this may have precipitated your question, that there's a lot of folks that have coexisting disorders, right, that are both having mental health challenges, but also using substances. And so, yeah, that's something that, that'll be my next presentation. I'll bring that data in. And if you're interested, that data is all available on the SAMHSA website, and I can certainly share those links with you and help pull some of it for you if you're interested.
So everyone, please mark down that Melinda just promised another presentation.
I know, I was thinking like, oh no.
So I'm excited. Okay, we have a question from Baya Camilla. Most juveniles serving time at the time they committed the crime were under the influence of some type of substance. Taking this into consideration, is the data correct, or do you think that the stigma on mental health plays a role in the figures collected?
So I'm going to try and answer that. So the data that's collected is collected just, so if you go to a mental health center, you know, state health authority, then your data is collected. So it's, you know, are you going to an appointment? And then do you have, you know, have you been involved in the justice system, whatever. So it's merely a tabulation of those characteristics that are of people being seen. So so whether or not a person lives in a community where their involvement with the justice system might have been predicated on their mental health challenges, that we can't tell from the data. All we know is like a list of characteristics. That's why data is, you know, although I'm proud to be a data nerd, data has a limitation in that it has lots of limitations, but one of them is that it has to be put in a context. And so when you look at your own community's data, you'll be able to better understand, well, this is the kind of, you know, juvenile justice system we have in our state, so that it will impact how we see our data. So that's why you can look at it like we did today, kind of just as a snapshot, but it doesn't tell you everything. You've got to get into, you know, states and communities and counties, and then you can answer some of those questions. But we can't answer that kind of question looking at the data that we looked at today.
All right. Melissa has a question about your gender data, which was so interesting. And her question is, at an earlier age, for those younger kids, Is it possible that girls are being left behind on being diagnosed, or what's your thinking?
Well, that occurred to me, right? And we know that girls tend to and they have more internalizing behaviors, which tend not to get noticed easily, right? So, someone who may have, depression or other things that isn't raising a ruckus may not get noticed because their behavior isn't disruptive in a classroom, in a larger family, whatever. I mean, you guys all know that kind of situation I'm talking about. So that was one thing that occurred to me, for sure.
Great. Another question about the data. Our folks are really interested in your data.
I'm glad they could join me.
Lisa Lambert has an observation. She feels like the trans percentages were a little low. She's in Massachusetts, and when they survey parents, they find it's about 3%. And it's the same as their children's hospital finds. What's your thinking?
I wondered about that, and I just don't know if that's a question of people not self-identifying, maybe, or not being recorded. So yeah, that could be, but I wondered about that too.
This is a great question, Melinda. This is from Joanne. Why is it that family and youth involvement has the most data that looks positive, with positive outcomes for children, and yet it's always underfunded?
So say that again.
So we have great data. We show positive outcomes for the work we're doing with our children. We all feel like our work is so underfunded.
So I'm smiling because that's, to me, one of the biggest reasons to collect this data and to make it available and to showcase it, right? Because that will illustrate that those interventions are working and kids are achieving, their milestones, things are getting better, kids are doing better in school. So that's why collecting that data and being able to showcase that what you're doing is working, and then being able to think about what part of what you're doing is really helping to move those kids to a better place. So to me, it's not only the stories, but it's being able to showcase that data. And that's what I think the power of presentations like this, of us working together, can really show, is that we do see positive outcomes with these kinds of interventions. And then it becomes, let's do what works, right?
Great. And Melinda, I know at some point I want you to scroll through the chats. We have so many comments thanking you for your values and the work you're doing. But let me get back to questions. This is also from Lisa Lambert. The burden on families has skyrocketed during COVID. We all know that. How should family support be adapted in order to address the mental health risks for children, their siblings, and especially their parents?
Can I turn that question back to all of you? I think that is a question that we need to wrestle with. And, kind of going back to those, the questions that I really think about a lot is, what does it look like? And what does work? And I think it really depends. And I don't have any data yet that will help us with that. I only have anecdotal stories. I have, know of folks that say that, their child had a therapist before COVID, had a relationship, and has been able to adapt to a telehealth environment. And so things are going fairly well. I have, another friend who says her child will not engage with the therapist at all, even though they had a very positive, longstanding relationship, and his behavior has deteriorated. And so I don't know if I have the answer, but I think you guys can help us understand better from what you're seeing, in your communities about what is working. Because I think families are under an incredible stress. And we need to unpack that a little bit so we can understand what's working and what maybe isn't so helpful.
Melinda, it is so wonderful to hear you asking for feedback from families. This is very exciting and something that we certainly want to do all we can to support SAMHSA with. But here's our next question.
I feel like this is a Stump Melinda time, right?
I never get to do this. This is so exciting. This question is from Gail Cormier. As we see our children transition into young adulthood and beyond, how do you see family peer support continuing throughout the lifespan? Because so many of our kids continue to need support.
They do. And we need to acknowledge that, I mean, if you think about how we changed thinking, right, about what a young adult was, what an older adolescent was. It used to be at 18, you were, merrily on your way. And, I remember, that same young caseworker working with young adults who were they were not much younger than me. I mean, we were only a couple, 3 years apart. But seeing them on their own, right? And I had, parents and some financial support. I mean, I wasn't on my own, and yet they were, and I was, in a very different situation. So I think we do need to talk about what does family support look like. And we have to think about how can we help parents change, because what I've learned from parenting my own young adults is that my parenting style had to change. It was not working the way that I had parented, and I've struggled with that and have learned kind of by doing. But we need to think about how can we change our models of family peer support to help families in that transition, but also ensuring that the other thing that we didn't talk about today is there's some very interesting data about how, we see a robust number of children engaged in the community mental health center system, right? And then we look and there's this gap. And then they start re-engaging when they're in their late 20s. And so that'll be our next presentation too. And so what a couple of us are doing a lot of thinking about is what's happening. Well, some of us can conjecture what might be happening, right? They're losing that contact with support systems, and then they're coming back around several years later. But what's happened in that interim? And to me, that's where parents and families can provide that key support. But we have to learn how that looks, because it doesn't look the same as it does when they're 10. And I think we know that. So we need to talk through that and figure it out.
Yes, we do. And we will continue to do that. We have a question from Signe Miller. Do you have any data on parenting classes and how families are supported by this? Is SAMHSA collecting any data on interventions like collaborative problem solving?
We don't collect data on that ourselves. What we collect data on is characteristics of folks being served, and then, what kinds of training and policy development and those kinds of things that are happening in the community, or what the grantee is doing. So we don't, that kind of data that you're talking about is like program evaluation data. And so often you can find that on like California Clearinghouse websites or other websites that are looking at particular interventions. And what's important there is to see, not only is that particular intervention shown to work, but in what population. So as we talked about in terms of adaptation, so does that intervention work in the kind of community that you'd like to implement it in? And so that comes from individual program evaluation data, and we at SAMHSA don't have that.
Great. So we will get some links for for the California Clearinghouse and some of those things, so we can get those out to folks. Next question is from Diana Altin. In the intellectual and developmental disabilities field, there has been good TA on supported decision-making as an alternative to guardianship. This is also a critical issue in the field of mental health.
Mm-hmm.
Is this something that your office is thinking about?
We've done quite a bit of talking about it, but the other thing is that, and this relates, and you may say a bit tangentially, but if you think about psychiatric advance directives and really talking that through, is a really interesting way of thinking about that as well. And so there is some talk with adults around that at SAMHSA. The thing that I keep thinking about is for those parents who, you know, having done a lot of work with parents in the child welfare system who often end up losing their children to foster care because of their, you know, psychiatric illness, is what kinds of supports can we put in for those families so they don't end up in the child welfare system? And what could that look like as a way of prevention in some, and I know it's a different way of thinking about prevention, but I've been doing a lot of thinking about that. Is there a way for us to think about helping folks make plans with kin or extended kin for their own children in those circumstances?
Okay. Next question is from Yes to Life. Are you aware of any data that indicate what percentage of children, adolescents, and young adults receiving services die by suicide annually versus those who are not receiving services?
So we have a lot of data about those who die by suicide. And so, but I cannot speak to particular data points, but I can get that information to Linda as well. I'm making a note.
That would be great to have. Thank you.
Mm-hmm.
We have a question from Yolanda Stinson. Do we have any information on grandparents raising their grandchildren and the struggles that we face? We're seeing such a rise in this, as you know, Melinda. Mm-hmm. Considering that we should be enjoying our later years and handling our situations, but we're taking care of our children. Mm-hmm. Do you have any data or any information for grandparents?
Well, so there's a lot of information available in like through child welfare type sites, because often if a family ends up having that kind of intervention, children often end up with grandparents through that kind of systemic interventions. And so there's a lot of data that way, and I can certainly get access for you guys for that as well. And that is a very significant concern, because, you know, folks are transitioning to a different stage in their life. They have different goals and different hopes and different, you know, dreams about what they want to accomplish. And perhaps raising a 5-year-old wasn't what they didn't quite figure in to that plan. And so how do you then not only care for a young child that you're very attached to, but also take care of their parent, right? And what does that mean to do both? And so, you know, looking at grandparent navigation programs and other supports that are in communities that can really help with that. But I think that's very significant, because it's not just caring for the young child, right? It's often caring for your child, the parent of that child, or, you know, so it we can't simplify it too much because it's not just all of a sudden becoming a parent again.
And Melinda, I am just about to get to the end of these questions.
Wow, I was like, oh my goodness, how many more can there be? But if you can, I will ask if you can save the chat, because that way if there's anything else we missed, and I'm trying to take some notes of things, but so I can get back everything that you guys have asked for.
Of course. We do have a sort of a question and a statement here from Barbara McCowan, just about supporting the whole family. And, you know, that whole family support that we all talk about so often. How do you feel from a SAMHSA perspective? Is that realistic that we can set up services in a way that it supports the entire family?
So I guess I'm going to tease it out a little bit, because I think I want to talk about it from a practice perspective, in that I think, yes, most definitely. We have to, you know, in terms of how to engage a family system and how does that look? I know that and then from the SAMHSA perspective, excuse me, that it's very difficult when, you know, when we talked about the SAMHSA data collection, what were we talking about? We weren't talking about families as units of service delivery. We were talking about kids, right? And so we're very aware of that, and we're very much aware of the fact that sometimes that can be a very artificial designation when it's really the family that's the unit that needs to be engaged. So you know, I don't have an answer for that, because that's the way it's set up. But you're exactly right that often looking at individual children and thinking about that is really not the way families present in terms of really needing services. And it's often not the way families are, you know, engaged in helping their young person heal.
So we have come to the end of our questions, and I really, Melinda, want you to have the opportunity to look at the chat box and see just how appreciative everyone is of your values and your attitude and your understanding of the need to support the entire family. In closing, I want to, first of all, thank Melinda so much for this. Truly, she does have an open door policy, and I'm going to ask you to exploit that in any way that it works. I want to thank our sponsors again and our board, who did such a tremendous job of bringing this together. Now, I do want to make a very important announcement. We're going to be sending out a survey. Melinda mentioned something about, you know, not having so much data for how things are going with COVID. We will be sending out a survey about education and mental health. Please look for that. You will be getting that when you are getting your evaluations, and you will be